Hello, and welcome to Basics to Brilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharad Everden, Haematology ST5 Registrar in the South West Deanery.
And my name's Dr. David Fazy, Haematology SHO, with aspirations to be a haemreg.
And let's get started on today's topic.
From basics
to brilliance. Hi David, lovely to see you again.
Yes, lovely to see you too. Although, truth be told, I'm slightly worried for our pre-podcast chat about how many case studies you've come up with. I hear you talking about stapling pages together. So,
yeah, you may have to rein me in.
I think I might be in for it today.
Yeah, and apologies in advance for anyone who can hear cars being driven backwards and forwards in the room above me. That is.
We're talking very small cars. You don't live in a mansion.
Yes. Well, they're not that small, but yeah, they're not real cars. Okay, right, let's get into it. So last time we talked about how to diagnose haemophilia A. Today, also sorry for the sniffing, I've got a bit of a cold. Today we're going to talk all about the management of haemophilia A. We're not going to talk about inhibitors because that is a whole separate podcast that we're going to talk about. So patients with haemophilia A and how you manage them with an inhibitor. It's just going to be about the basic management to start off with. So hopefully by the end of this podcast today, you'll know how to manage somebody with haemophilia A, the basic emergencies and elective things. And one other thing to say for listeners at home is probably it would be worth revising the podcast on how we do factor assays, just so it's fresh in your head. It might help you to think about what we're talking about today.
And a cheeky plug for our numbers.
Yes.
Yeah, cheeky plug for our numbers.
Has David revised the factor assays?
No. I thought it was more appropriate
to come in completely blind.
Completely blind.
But save yourselves at home.
Yeah.
Okay, so without more ado, the first thing to always remember whenever you're thinking about management of haemophilia A, or answering a question in an exam, for example, is that you must involve the MDT approach. Who do you think might be important in the MDT for management of haemophilia A patients, David?
So I guess the haematologist top of my list.
Very good. Yeah.
A lot of trusts have hemostasis nurses.
Yeah, definitely.
So the specialist nurse team. I guess depending on whether they're going for procedures and things, that could be dentists or orthopedic surgeons or something like that.
Yeah.
And then physios.
Yeah, physios for joint health, absolutely.
And then I guess if it's super serious, we're talking about things like psychologists or social workers, supportive, more pastorally type people.
Perfect, exactly. Play therapy, your psychologist, these are really important. A lot of these patients are going to be children needing treatment. So you've got to bear that in mind. And that's, for me, I haven't done much in the way of peds, so that's just something to remember. And they can be really helpful in terms of getting bloods off patients, getting IV access, that kind of thing. So yes, and then talking very basically about an overall of the structure of how we manage haemophilia A within the NHS. Do you know how it's sort of organised across hospitals?
Oh, is this something to do with? And I might be making stuff up here. Is this the CCC, or are we talking about sort of how? Okay. Yeah.
And what does the CCC stand for?
Something care centre.
Comprehensive care centre.
Oh, we're close.
So it's a hub and spoke model. So you have your big hub, which is your comprehensive care centre. So for the South West Deanery, it's Bristol, for example. And then you have your sort of spoke hospitals around the outside. So your district general hospitals like Cornwall, even bigger places like Derriford count as such. And so most of your day-to-day management of patients with haemophilia A will be in your district general hospital, unless obviously they live in Bristol. But then they will have things like annual reviews are always done at the comprehensive care centre. And and they may have some blood tests that are sent on a sort of interval basis to the comprehensive care centre, and certain drugs can only be prescribed by your CCC as well. And they're also act as sort of the hospital that you would ring if you needed advice about something that was a bit unusual or wasn't going so well. So yeah. Okay, brilliant. So then let's start with a really open question. If I were to ask you, David, what are the key aspects of haemophilia management? How would we divide it into the types of management that we can do? Where would you start? Do you have a sort of idea in your head as to how to organise it?
So I guess it's how they've presented in my head. So I guess if we know that somebody has haemophilia, you're probably thinking about prophylaxis.
Okay, yeah.
But if they have sort of turned up in a state bleeding into joints and in a lot of trouble, I guess the management's very different there. That's, I guess, or we talked about very briefly, I said about procedures with, say, an ortho. So I guess how they present, whether they are someone that we're prophylactically treating, someone in a crisis, or someone who we are lining up for a procedure.
Yeah, brilliant. And I think that's a really helpful way to first think about how to divide management. I think about it in terms of what we call on-demand treatment, which is basically unplanned. So support around injury, a surgery or a procedure, bleeding, and that can be emergency surgery or elective surgery. So sort of on-demand therapy to help get somebody over something, some sort of hemostatic challenge. And then you've got prophylaxis, which is a really important part of haemophilia management, which is easy to forget, especially as adult haematologists, because a lot of the prophylaxis is more in the younger age group. And so that's a really useful way to think about it, and to then think, okay, well, what drugs can I use to do on-demand therapy, and what drugs can I use to do prophylactic therapy, and what are the aims of each? So what is the aim of prophylaxis then?
So I guess to prevent bleeding into joints, to offer sort of long-term protection or reduce further bleeds, increasing sort of quality of life and things like that.
Yeah, okay, good. So, I mean, I'm glad you said bleeding into joints, but also don't forget that the actual primary goal of haemophilia care in general is to reduce death rates, which was from intracranial hemorrhage. So, primary prophylaxis is actually, well, not primary prophylaxis, sorry, prophylaxis in haemophilia A is about firstly aiming to reduce death rates and intracranial hemorrhage, and then secondly is also about reducing the incidence of joint bleeds. Who gets prophylaxis in haemophilia A? Is it everybody? Should we?
Is it to do with? Is it based on severity?
Yes. Okay. Let's just recap severity for our listeners at home. So severe was less than 1.
1%. Yeah.
Moderate.
Was 1 to 5.
Yeah.
And then mild was 5 to anywhere below 50. Was it
6 to 40?
6 to 40.
Yeah. Yeah. So moderate is 1 to 5, and then anything above 5, so 6 and above, is mild. Yeah. Good. So would all of those patients be eligible or require prophylaxis?
I suspect the people in the mild camp probably don't need any kind of prophylaxis.
Yeah.
Unless there's something specific they're going for, I don't know, a procedure or something. But you said that's on demand anyway. So in answer to your question, no, I don't think so.
Yeah, exactly. So prophylaxis is going to be all of your severe patients. We would recommend prophylaxis. So if you've got a level of less than 1 or 1%, and then most of your moderate haemophilia A patients. So where you've got levels between 1 and 3, that's probably sort of what we're talking about there. If you never get joint bleeds and your level's like 5, then you probably can get away without prophylaxis. But it's all of your severes and most of your moderate haemophilia A patients that will have prophylaxis or be eligible for it. And in terms of the different types of prophylaxis, do you know how we talk about that or what the terminology is?
So I've heard primary, secondary, and tertiary.
Okay.
I couldn't tell you what's what and who gets which bit. So I'd probably ask a reg if I knew one.
So primary prophylaxis is prophylaxis that is given to a patient before a second joint bleed. Okay. So the idea of it is that it happens actually before the first joint bleed or immediately on the first joint bleed. And so if you've got somebody with severe haemophilia A, you would recommend and plan to start primary prophylaxis at the age at which they become ambulatory. So this is what we were saying about 12 months last week, and at the latest, sort of 3 years old. And so the aim of primary prophylaxis is that the child reaches maturity with normal joints, and it's about primarily preventing any joint bleeds, ideally, but certainly it needs to start before a second joint bleed occurs. Okay.
Yeah.
So who should get primary prophylaxis? As we said, there's clear evidence of benefit in patients with severe haemophilia, and they start around the age of 1. Any child that's had a spontaneous intracranial hemorrhage should be offered primary prophylaxis. And thirdly, moderate patients with a level of less than 4. So those are your moderate patients with a level of between 1 to 3. So that's primary prophylaxis. Then we move on to secondary prophylaxis. So secondary prophylaxis, unlike primary where it's before a second joint bleed, secondary is after a second joint bleed. Okay, but the idea of it is that, okay, you've now had 2 bleeds into a joint. It can be different joints, but we want to therefore start you on prophylaxis to prevent you getting joint disease. So these patients probably have got some subclinical established joint disease just from having a bleed, like 2 different bleeds. But what we want to make sure is we limit the kind of subclinical joint damage, and we basically prevent further bleeding, and we maximize long-term function as a result. So there was a trial called the ESPRIT trial, which showed a benefit of primary and secondary prophylaxis in your sort of joint health overall, which isn't a surprise. And then tertiary prophylaxis is basically prophylaxis that you offer somebody after the onset of joint disease. So you have sort of missed the boat in terms of preventing joint disease, and that can either be on clinical diagnosis of a problem with the joint, or with a radiological evidence of joint disease. But the idea of tertiary prophylaxis is to basically slow down the progression of joint disease, reduce the pain that they get, and improve their quality of life. And there was a trial called the SPINART study, which was a randomized controlled trial, which looked at tertiary prophylaxis versus just on-demand therapy. And it did show that you could basically halve the incidence of chronic pain in these patients. So it is beneficial, but more for a quality of life point of view. Does that make sense?
Yeah, I was going to just ask about what kind of joint disease are they sort of experiencing? Is it mostly functional and pain, or is there sort of actual physical damage to their joint structures?
I mean, it basically, as we were saying last week or last time on the podcast, they get a bleed, and then the blood and the hemosiderin is very irritant, and then they get sort of vascularization and growth of the membrane. So you can basically get deformities, lack of range of movement, pain, lots of those things that you've mentioned. And so it's about trying to prevent all of those things, really.
Okay, thanks.
Yeah, no, that's a good question. So in terms of phases of treatment, if a child were to be started on primary prophylaxis at the age of 1, do we then see these people as adults on primary prophylaxis? Have you met many adults with haemophilia A on primary prophylaxis?
I'm trying to think. I haven't met many in my time.
Yeah.
Obviously, and when I have met people, they have come into the day case unit requiring, sort of the episodic on-demand treatment we've been referring to.
Yes.
So, and they usually know how much they need and how many they've taken and things like that.
Yeah.
So, I don't know. I definitely haven't seen many on the tape come in that have sort of said, "Oh, I'm on this on a regular basis." So,
exactly. Yeah. So I'm glad you say that. And that's why sometimes it's easy to forget about primary prophylaxis, secondary prophylaxis, because it's seen more in children, and it's because there are different phases of treatment. So you get this initial introduction of primary prophylaxis during the first 3 years of life, when they're kind of mobilizing, they're crawling, then whacking themselves basically. And then you establish regular dosing in childhood. And then you modify to increase the doses of primary prophylaxis that they need during teenage years, when you're like falling off bikes and falling off skateboards or surfing, whatever.
Doing whatever young people do.
Exactly. And then you modify that dose again and reduce it back down when they go into adulthood, because you're not falling off skateboards or
Become boring and old like us.
yeah, exactly. And yeah, thanks. I actually went
But
surfing this weekend, I'll have you know. I'm not that boring. And
speaking for
then
myself.
and then basically by the time you become an adult, 30% of the severe patients with haemophilia A can actually safely stop primary prophylaxis in adulthood. So it's something that's very much covering that kind of accident prone era.
Yeah.
And also that time where your joints are all growing and developing and they're just so precious. So it's
Yeah.
that combination. So those are the phases of treatment. You start off at the beginning, you get the child and the parents used to giving primary prophylaxis, you get that on established regularly in childhood, you up the dose during teenage years, you come back down during adulthood, and then by proper adulthood, if you're sensible and you're not playing rugby, then you know you can actually stop prophylaxis safely. So that's the kind of phases of treatment that you would expect. So what do we give to provide prophylaxis for patients with haemophilia A? What drugs can we give?
So I haven't got any good names, but as far as I'm concerned, it's factor 8 or factor 8 concentrate.
Okay, yeah, good. And is factor 8, you've described it as factor 8 concentrate. Is it from humans? Is it recombinant in a lab?
I hear the words recombinant quite a lot.
Okay, yeah, so it's recombinant. So what this means is we've taken the DNA gene and we've stuck it into like, I think they usually use like these hamster kidney cells in the lab
Okay.
to like a random bit of useless trivia. But they
We
basically,
do like it when you get the zoology out, especially the lab stuff.
I'm just trying to keep it diverse, you know? But yeah, so you basically get that recombinant bit of DNA and then you grow the factor from modified cells basically in the lab. The reason why I'm flagging this as an important thing is because of obviously the infected blood inquiry, and patients will still be looking for reassurance that you're not going to risk them getting hepatitis B or C or HIV. So they are recombinant, which means they carry no infection risk. And that's the case for all of the factor 8 products that are available. So in terms of the name, don't get too hung up because in the NHS it depends on what we manage to source as the cheapest thing at the time. But there are, you'll have heard of maybe something called Advate, which is often used, or there are second generation recombinant factor 8, like Refacto AF. I think our hospital's using Refacto AF at the moment. There's also Cognate, which I've never heard of, and Heli-X8. They all end in 8, which ATE,
Okay.
which also is like the
Yeah.
number 8, so it's kind of useful to recognize. But essentially, you're using recombinant factor 8. Do you know anything about its bioavailability and how we have to give it?
I know nothing.
Okay, so it has to be given IV
Okay.
because it's a protein structure that you can't eat it, you can't subcut inject it. So this is a big issue with factor replacement.
Especially, I guess, if you're doing it in children.
Exactly. And do you know the half-life of factor 8?
So I know you can get extended half-life versions.
Okay.
So, but and I think it's the standard dosing is like 2 to 3 times a week. So I'm guessing a couple days.
Yeah, okay,
or a day. Yeah.
so the half-life's 8 to 12 hours.
Oh, okay.
So it will have halved by 12 hours, basically.
Yeah.
So we, as primary prophylaxis, will dose 3 to 4 times a week. So like
Okay.
Monday, Wednesday, Friday, Sunday, that kind of thing.
Quite a commitment, isn't it?
Yes, it's a massive commitment, and we're talking about this intravenously as well. So what this means is that children need to have a chronic venous access device inserted, like a portacath.
Yeah.
And that comes with it risks of infection and clotting, and it's something that a child and parents have to get used to using and keeping clean, and so it's a big thing. And that's why I said at the beginning about considering all of the people that you might need within the MDT.
Yeah.
In terms of dosing, so do you know when you give recombinant factor 8, what dose leads to what change in the blood level?
So I've never given it. So
Okay, that's fine.
I don't know nothing.
Fine. Okay, that's fine. So recombinant factor VIII, for every 1 international unit per kilogram that you give, you will increase the factor VIII level in the blood by 2 international units per DL.
Okay.
Okay, so for every 1 international unit per kilogram dose that you give, you will increase the level of factor in the blood by 2 international units per deciliter. And that is the key takeaway message from today, if you take away nothing else in terms of management of haemophilia A, because
Yeah.
this will allow you in the middle of the night to do a back of the envelope calculation and work out what you need to give them. Okay?
Okay. And I take it there are specific reference ranges that you're aiming for within certain
We'll
conditions.
come back to that because that's all
Okay.
about
Jumping the gun. Yeah. Okay.
on-demand therapy. But actually, it's a good question because you would assume, I think it's logical to assume that you would be dosing patients in primary prophylaxis to a peak level that you aim for. But interestingly, you don't do that for primary prophylaxis. You aim for a trough level of above 1 to 3. Okay.
Okay.
So you're only looking for a trough level of between 1 and 3. So you take that blood sample before you then give the next dose of Refacto AF or Advate, whatever. But actually, what you're really aiming for is whatever level is required to prevent that patient from bleeding, and that will be individual depending on, if you've got a mental child like my boy, he'll be running around. He'll need a much higher dose than some good little girl that sits still a lot of the time and does colouring. So they say that you dose between 25 to 40 international units per kilogram, generally speaking, 3 to 4 times a week.
Yeah.
But you're actually only aiming to keep the trough between 1 and 3. Okay, so above that level, because you don't want it to dip below 1%, even when it's at its lowest.
Yeah.
But really what you're titrating it to is clinically whether they have any breakthrough bleeds. And so that will be really individual. And obviously then that also dictates how you change dosing through different phases of that individual person's life, depending on whether they're somebody who sits at home and does puzzles or wants to fall off skateboards in a skate park. Does that make sense? Yeah?
Yeah.
Okay, perfect. So you also mentioned extended half-life products. Do you know anything more about that?
Only what I'm sort of putting together with the words. I'm guessing that they sort of have a longer half-life, so you only need to give them less often a week. I don't know what they've done to the protein to make it last longer or anything like that.
Yeah, but you're exactly right. So basically, the problem, as we said, with Advate and other recombinant standard factor VIII replacement therapy is that it's got a short half-life of 8 to 12 hours. And so you have to dose it like 3 times a week, which is a massive commitment for families and children. So then they develop these extended half-life products, which by definition need to have a half-life that's at least a ratio of 1 to 1.3 compared to, so like the half-life of factor VIII to half-life of the extended half-life product needs to be 1 to 1.3. So you do actually have to demonstrate that in patients when you put them onto an extended half-life product, because that can vary with different people depending on how they handle it. But essentially what we've done is taken the structure of factor VIII and then done something to it to make it last longer in the body. So one option is you can pegylate it, which basically protects the factor VIII from proteolytic enzymes. And the one that we classically have for that is called ADINAV. There's also ESPRIT. I don't know if I've pronounced that correctly, but ADINAV is the main one. Then you've got a second option is that they basically fuse it to human albumin. And then that takes advantage of the natural half-life that's longer of albumin. And then the third thing they can do is they fuse it to the FC region of a human antibody, IgG. And that basically takes advantage of the FC receptor recycling pathway, which basically maintains antibodies in the blood. And so L-COTA is an example of that. Either way, they can either be pegylated, they can be fused onto albumin, or they can be fused onto the FC region of a antibody. But basically, it results in them having a longer half-life. And it means that you can basically change dosing from 3 times a week to twice a week for primary prophylaxis. Dosing is the same in terms of how it affects the amount of factor in the blood. You aim again for the same trough levels and what is required clinically to prevent bleeding. But it's just a slightly reduced treatment burden. You can't start people on extended half-life products because there is a theoretical risk of developing an inhibitor more using extended half-life products, because obviously the factor VIII looks even more weird than to the immune system than normal factor VIII. So they say you have to have the first 50 doses of factor VIII need to be normal recombinant factor VIII before you're allowed to switch to an extended half-life product. Okay?
Got it. Yeah.
And then we've got a drug that's fresh, hot off the press since February 2025, which is called EFA. And you're going to want me to try and pronounce the actual name of it.
Oh yeah, no, this is the only part of the entire podcast where I get to feel remotely.
Oh no. Okay, so it's Efanesoctocog.
Wow.
We just call it EFA for short, okay? But basically, this has recently been released as what we call a very extended half-life factor VIII product. And so much so that in trials, you basically you only have to dose once a week, and that even 7 days after a dose, it was still at 15% of what you originally gave. Yeah, so really good. The trials that you need to know are the Extend 1 trial and the Extend Kids trial, which basically compared EFA versus recombinant factor VIII replacement and showed that it was superior at preventing bleeding. And also they've done a sort of meta-analysis of an indirect comparison between Emicisimab, which we'll talk about in a minute, in the Haven trials, and the Extend 1 trial on EFA. And it does suggest that there are lower rates of bleeding and higher health joint scores with EFA compared to Emi, which is interesting because I used to be obsessed with Emicisimab, which we'll talk about in a minute, and thought it was like this most amazing drug for haemophilia A. But actually, now I'm starting to think that maybe some of these very extended half-life products might actually be the answer. So this is an exciting drug. I've not met anyone on it yet, but it would be a good option for somebody. The issue with it still is that it's intravenous only. So you are still going to need to have IV access at least once a week. So does it really reduce the need for having a chronic venous access device like a portacath? I'm not sure.
I guess it's just the not getting poked with something spiky as much.
Yeah, exactly. And then the last thing that we could use for prophylaxis is a drug called Emicisimab, which I've just said I'm completely obsessed with. Yeah. Do you know anything about it? It's very cool.
So, I mean, it's a MAB, so it sounds like a monoclonal.
Yes, very good.
And I imagine it somehow mimics the function of factor VIII. I'm not sure what it binds to, and I'm not sure how it does its job. So yeah, that's all I can offer.
That's a pretty good start, to be honest, David. So it's a bispecific antibody.
Oh.
And it therefore replaces factor VIII. So bispecific meaning it can bind 2 different things. And it's a monoclonal antibody, as you say. So it binds together factor 9A, so activated factor 9, with factor 10. Thereby activating factor 10 to 10A.
So it replaces that cofactor function.
It completely replaces factor VIII. How cool is that?
That's
quite cool, isn't it?
That's very heme nerdy, isn't it?
Yeah, it's really cool. So, and the lingo is you call it Emi rather than Emicisimab.
Okay, I'm not cool enough.
And now you've got EFA and now you've got Emi. So yes. Essentially, I thought this was like the panacea of haemophilia A. I was like, that's it. We've cured haemophilia A. That's what it seems like on paper. But I've done a lot of reading and listening to things about it to try and get an idea of what it's really like meeting a patient on Emicisimab. And actually, it renders them with a sort of mild haemophilia A phenotype. So it doesn't cure them completely. So they can still get bleeding as if they have mild haemophilia A. That's the equivalent.
Okay.
It doesn't.
So do they have that sort of as a regular infusion?
So that's the other really amazing thing about emicizumab. It's subcutaneous.
Ah,
And its
dream.
half-life is 30 days.
Wow.
Yeah. So
As you
they
said,
can
the
basically,
panacea.
I
It's
know. So you can
ticks
have a
all the
subcut
boxes.
injection, you don't need any IV access, and you can do it once every week or even once every 2 weeks.
And
Um,
how much has this been rolled out to the ye yokels of
yeah,
the NHS world?
yeah. So it's commissioned and funded only to comprehensive care centres, but that
Okay.
doesn't mean that you can't get it if you don't live like in Bristol, for example,
Hmm.
obviously. In 2018, NICE licensed it initially just for haemophilia A patients with an inhibitor, because
Yeah.
this obviously gets like,
Yeah.
yeah, bypasses the inhibitor. And so that was a big breakthrough for patients with haemophilia A with inhibitors, which we'll talk about in another podcast.
Yeah.
Then in 2019, they then licensed it for severe haemophilia A without the need for an inhibitor. So there are now two indications in which you can use emicizumab. You can use it in haemophilia A of any severity, but they must have an inhibitor, or you can use it for severe haemophilia A without an inhibitor. And so you use it as prophylaxis. It's not used as on-demand therapy. And you do an initial weekly loading dose for 4 weeks, and then you drop down to a smaller dose if it's a weekly schedule, or you continue on the same dose every 2 weeks if you do it as a fortnightly schedule. And if you're switching over from like just a standard recombinant factor VIII like Advate to emicizumab, then you basically keep going with your factor VIII prophylaxis for 7 days. You overlap them by 7 days with the emicizumab before you can then stop the recombinant factor VIII. So that's emicizumab. Just to briefly touch on the trials, because you'll hear people talking about it. The Haven 3 study was the key study. And that was the study that showed that emicizumab was effective at reducing bleeding. I do have issues with this trial in that it was a randomized controlled trial, but it looked at the use of emicizumab as a prophylactic agent, so regular dosing I think it was every 2 weeks in the trial, versus on-demand therapy for the recombinant factor VIII, which is not a fair comparison, is it? It should really have been prophylaxis with recombinant factor VIII versus emicizumab. They obviously designed the trial to make emicizumab look really good because they're comparing prophylaxis with emicizumab versus on-demand therapy with factor VIII.
Did they not think anyone would notice?
I know, you do wonder, don't you? But
Yeah.
I guess their primary outcome was just that they showed that it was
Yeah.
effective.
Yeah. Yeah.
Um, I would say there's limited data for use of emicizumab in children, less than 2, but it has been used in babies. And as we said, the major pros are that you can give it subcut, that it bypasses inhibitors, that you don't need IV access, and it's got a really long half-life. So,
Mm.
yeah, really exciting drug. So I guess to provide a balanced view on emicizumab, we should also talk about the cons of emicizumab. Can you think of any?
Um,
Bit of a mean question in a way, but
yeah, yeah, yeah. Hey, have you heard of this drug you've never heard of? Think of some bad idea. It you'll make an excellent consultant, Harry.
Oh, I'm sorry. I'm so horrible, aren't I? No, I just meant more in terms of like, in more general terms, if you've got a patient population that now are starting their child on emicizumab from a very young age, from like the age of 1, I've said that this only renders them still of a phenotype of mild haemophilia A. So they could then still easily get a breakthrough bleed on emicizumab. And if they do, how are they going to manage that?
I suppose they give them normal recombinant factor VIII.
Yes, they would have to. But the thing is that
It's already
this is
the
now a
factor
child
10
that,
and stuff are bound up to things, aren't they? So
well,
actually, your response to it's going to be worse.
it's more just the fact that like we're now seeing families that have never had to that have got children that don't have a portacath. They've never had to get IV access before, and so they end up having to go to A&E basically, and then they have the kind of classic experience that you may have in A&E, particularly over the winter, to get a treatment dose of recombinant factor.
Yeah, I
So
can see that being traumatic.
exactly. So it would be different if it completely cured them of haemophilia A, but it doesn't. It renders them this mild phenotype where they can get breakthrough bleeds. I mean, you can still get breakthrough bleeds, obviously, with primary prophylaxis as well, using recombinant factor. Um,
But at least they will have
but at
the
least they'll have
logistical bits in place. Yeah.
exactly. And if they do get a breakthrough bleed in that situation, they can often treat it at home because they know how to give things IV, as they're not in that situation on emicisimab.
Yeah.
So that is one of the cons on a practical basis. The other thing is that and I guess the other con is that you can get breakthrough bleeds because it doesn't cure you of haemophilia A.
I was just checking my checking our future kind of thing, and I guess we're talking in the future about upcoming gene therapy and stuff.
Yes, yeah.
Okay, fine. I'll nip that in the bud then.
The other thing is that patients, obviously, emicisimab was initially given to patients with an inhibitor. And one of the drugs that we can give patients who have inhibitors in haemophilia A is something called FEIBA, which stands for, we love an acronym, Factor VIII Inhibitor Bypassing Agent. And essentially, it's the same as PCC, so prothrombin complex concentrate that we give for like reversing warfarin, so factors 2, 7, 9, and 10. But the factor 7 in FEIBA is activated already, as in warfarin reversal in like using beriplex or octoplex. It's not, it's inactive, so it's 2, 7, 9, and 10 inactive. As FEIBA is 2, 7, 9, and 10, in which the 7 is activated. And so we use FEIBA commonly in patients that have bleeding and have an inhibitor in haemophilia A. Spoiler alert for the next podcast. But
This is me scribbling it down, so I've
yeah,
ready for
you
you.
got a heads up for that one. But basically, when used together, when FEIBA is used with emicisimab, some patients did develop cases of a MAHA, so microangiopathic hemolytic anemia. So basically, you mustn't use FEIBA for breakthrough bleeds for patients on emicisimab, which is really important to remember because that is the drug you probably would go to in somebody who's having a breakthrough bleed and has an inhibitor. To the extent that actually you have to remove FEIBA and bypassing agents from the patient's home where they might have had them as emergency treatment to administer at home before you can start them on emicisimab because you just don't want them to accidentally get that. And that's something that we need to remember as registrars. Also, it's important to say that the Haven studies, they excluded all patients with risk factors for thrombosis, which is obviously not the real life population.
Yeah.
And real world data have had occasional reports of MIs and PEs in patients on emicisimab. And the other thing that, again, we'll talk about more next time is that if you do immune tolerance induction therapy, which is essentially like a desensitization program you can undergo to get rid of an inhibitor in haemophilia A, you can lose that tolerance to factor VIII if you switch to emicisimab because it doesn't look the same. So sometimes people will give like low dose intermittent factor VIII recombinant therapy just to maintain tolerance in patients if they choose to go on to emicisimab. So yeah.
Interesting.
It is interesting. And we'll come back to management of bleeding on emicisimab in patients with inhibitors next time. What do you think, just thinking about the mechanism of action of emicisimab, what do you think it might do to the APTT? He's thinking.
Yeah,
Listeners at home, he's thinking.
yeah, yeah. It looks painful. So a person who has a low factor VIII is an increased APTT.
Mm-hmm.
So I assume that it reduces the APTT.
Yeah, exactly. It short circuits it effectively.
Yeah.
Even if you've got subtherapeutic levels of factor VIII, or even if you've got months after your last dose of emicisimab, so subtherapeutic levels of emicisimab, you're short circuiting your APTT because you don't need the cascade that we usually activate, like the 12, 11, 9. Instead, you're just giving emicisimab, which just bam, activates, goes.
Yeah.
It shortens the APTT, which is annoying, but it also means that we then can't measure how much factor VIII the patient has or how strong their inhibitor is when they're on emicisimab. Because if we just like think about the chromogenic assay, which we use to measure factor VIII, you have your plasma sample, which is your patient's factor VIII, which you add to a kit which contains activated factor IXA and activated factor II, i.e. thrombin, plus calcium and phospholipid. And the 2A binds and activates the patient's factor VIII, and then that causes the production of activated factor X. And then that activated factor X, you then assay the production of that using a chromogenic substrate. So what you can do is you can order a special kit, a special chromogenic assay for patients on emicisimab. And the big difference there is that instead of it containing human factor X, it contains bovine factor X, i.e. from a cow.
Yeah.
Emicisimab is able to cross-link 9 with 10, so 9A with 10, if it's human 10, but it can't cross-link cow's factor 10 with it can't bind it basically. So
Yeah,
it can't
but a human factor VIII will activate it.
Yeah, so emicisimab can only bind human factor, basically.
Yeah.
So what you do is you order a kit which contains bovine factor X, but obviously normal factor VIII because that's whatever the patient's got.
Yeah.
So then you can still assay the amount of factor VIII the patient's got because you've basically removed the ability of emicisimab to interfere by swapping the factor X from human factor X to bovine factor X.
But what I'm saying is the human factor VIII in the cascade that they have can activate bovine.
Yes.
Yeah. Okay.
Yeah. So yeah, exactly. And the other thing to say, so that's one thing to say, is how it affects the lab. The other thing is when you start somebody on emicisimab because they have an inhibitor for Haemophilia A.
Yeah.
There's one other test that you should do before you start them on emicisimab, and this is finding out whether the patient's antibody that they are specifically producing, unique to them, against factor VIII, whether it works against human factor VIII only, or whether it works against porcine factor VIII, this time from a pig. And you might be like, why would I want to know that?
Because we're hematologists.
No, it's not just completely pointless, like, oh, I just wonder whether this might work against the pig factor VIII. No, it's because we can use porcine factor VIII, that again is recombinant, so made in a lab, using DNA, the DNA sequence for factor VIII in a pig.
Yeah.
And we can use porcine factor VIII, just like the bovine factor X does work in our clotting cascade with human factors. Porcine factor VIII can work with our other human clotting factors to clot in real life. So if someone's got an inhibitor and their inhibitor only binds to human factor VIII but doesn't bind to porcine factor VIII, then you can give porcine factor VIII as a way of managing a patient with breakthrough bleeding on emicisimab with an inhibitor.
Very nice.
Does that make sense, or have I just like completely?
No. I've got you.
Yeah, you got it.
So effectively, there's redundancy in the way that our clotting works, but the specific antibodies can only bind something very specific to human.
Exactly. I mean, sometimes patients do have inhibitors that bind to porcine factor as well. It just depends on how broadly specific the epitope is, I guess, that they bind to. And so therefore you have to do a Bethesda assay for that patient's inhibitor. But instead of using, so do you remember your Bethesda assay is like a mixing study, a glorified mixing study, where you take your patient's plasma as the source of inhibitor, and then you do a 1-to-1 mix with pooled normal control plasma with a known source of factor VIII. You incubate it together, and then you measure the residual factor VIII left at the end, and that allows you to quantify the strength of the inhibitor. Well, instead of doing just a standard Bethesda, you swap out that normal control plasma and you swap it out for pig factor VIII. And then you incubate it, and then you see how much the pig factor VIII level goes down with incubation with the inhibitor. Does that make sense?
Yeah, I'm going out on the curve here a little bit.
I
I'll
know.
agree with you, but yeah, I'm getting lost.
Oh no. Well, where did I lose
No,
you?
no, no. I just I'm trying to rack my brains back to my Bethesda
I was going to
days
say
before we were chatting.
you'll have to listen to that podcast again then,
Yeah,
David.
yeah. I've been
Um,
caught out.
yeah, you have. Yeah, he hasn't done his homework.
Uh, Pull
Okay.
from me.
So yeah, so that's Emicisimab. So I have prattled on about that for too long, but I got excited. Sorry. So essentially, we've talked about prophylaxis, primary, secondary, tertiary, and we've talked about the different agents that we can use to provide prophylaxis, which are David.
So your your standard half-life ones, which names
Yep,
I'm still not used to.
that's
There's
fine.
the
Recombinant factor VIII, so
the
Advait,
recombinant
Refacto
factor rate.
AF.
There's the extended half-life recombinant
Yep,
factor rate.
yep,
And then we talked about Emmy, because I'm cool enough to say it now, and
yep,
Effa, which is
yeah.
a very long one, and Emmy is our bispecific, which we can give subcut.
Perfect. Brilliant. Okay, so that's prophylaxis in a nutshell. Um, Now let's talk about on-demand therapy. So this is going to be the bulk of what you'll be doing and calculating when you're a heme reg on call. So I like to think about what agents we have, what arsenal we have up our sleeve for on-demand therapy. And it really depends on whether your patient has an inhibitor or not. So if they have no inhibitor, what sort of things do you think you could use to treat somebody on demand?
Would you give recombinant factor rate straight
Yes,
as it is in large
exactly.
quantities? Yeah.
Yeah, and that's usually what you reach for is something like Advait or Refacto. Yeah. You can, if they're on an extended half-life product, you can technically give them a dose of that instead. Um, if they're already on it and they haven't had a dose recently. But generally speaking, it's just easier to use, your standard recombinant factor VIII when it's on demand because you just know what the half-life is and you know when to do levels and that kind of thing. Anything else that you can think of that we can use for on-demand therapy for patients with haemophilia A?
Um, Tranexamic acid.
Yes, always. I'm
Thinking
glad you
slightly
brought that
outside the
up.
box.
No, no, that's really good. I'm really glad you brought that up because I would have forgotten to say that. But always tranexamic acid. Yeah, 1 gram TDS, oral and IV equivalent dose.
And then, I mean, you talked about fever, but I guess that's sort of inhibitor based.
Yeah, that's for inhibitors.
Okay. That's about as far as I've got.
Okay, so then the other big thing is DDAVP, which we'll come back to.
Yes.
Okay, brilliant. And then in terms of patients with inhibitors, we're going to talk about that next time. So we'll just leave those
Cool.
out for now.
Park that.
Yeah. So, what do you think is one of the most common presentations in terms of bleeding sites in haemophilia A?
Elbows and knees.
Yeah, joint bleeds, great,
Yeah.
and elbows and knees,
Yeah.
and ankles. So anything you can hit, basically, anything that's not got lots of padding around it. So
Yeah.
not the hip we established last time.
Yeah. No. Despite me trying to sell you on hip, it was a no.
No, and you've got different kinds of bleeds. So when you see a patient, you need to think in your head: is this an early bleed? Is this a moderate bleed? Is it a severe bleed, or is it a rebleed? So early bleeds, the patient will be the expert in terms of knowing what the early signs are for them. So it can just be a sense of fullness or stiffness or a tingling in the joint. The patient almost describes it like an aura, and they have a full range of motion. So that's an early bleed. A moderate bleed is where they do get some pain with some swelling and some restriction of movement. And then severe is where you've got severe pain and the joint is completely immobilized from all the blood in the joint. And then obviously a rebleed is just basically whenever someone has a bleed into a joint that you've just been treating within 72 hours of stopping treatment. So, do you know so now you asked before about aiming for target levels, and obviously we just talked about trough levels only in prophylaxis
Yeah.
and clinically preventing bleeding. But obviously you're right, in on-demand therapy we aim for a certain peak level, and it's really worth having in your hematology notes or wherever you have your reference to have a table with your ranges that you're aiming for different clinical scenarios. So do you know I don't really expect you to, but what do you have a guess at what you think you might be aiming for in terms of levels in RU per DL, so we can think about it like a percentage, for moderate and for severe joint bleeds? What do you reckon we would be aiming for?
So I guess this is a complete guess is somewhere over 50 would
Yes,
be what
exactly.
I'd be aiming for in
Yeah,
a minor, because
yeah,
that's the kind of the cutoff number, isn't it? If you're at
exactly. It's like
50%
50.
factor eight, you're kind of, yeah.
You're good.
So,
Yeah.
and then I imagine if you're in a severe case, probably higher, heading towards 80 or above.
Yeah, really good, David. So moderate, we say 50 to 60. Severe, we say sort of 60 to 80. And remember, that's your peak level. So you're not going to be at that level the whole time. So as it starts to decay, you're going to be below that level. And usually they need daily dosing. And you will dose them to keep that level for sort of 1 to 2 days after resolution of the joint pain. So it's not just until the pain goes away, it's a couple of days afterwards as well. And I really recommend that you get a table up at some point and make a table with the levels of which you aim for different clinical scenarios. And yeah, I guess the next thing we could do is we could talk about, well, let's just talk about the basics of the management of a bleed. So do you know what the sort of timescale is of what you're expected to do for somebody that comes in to A&E with a joint bleed, for example?
No,
Okay,
never been important enough to be asked.
fine. Okay, so you assess them within 15 minutes. That's the expectation, is you need to assess.
Where is this place you're speaking of?
I know. And then you have to treat them within 30 minutes.
Okay.
And patients with haemophilia, in my experience, do know that that is the sort of what is expected for their care.
Okay.
So it is something that unless you've got a major emergency going on somewhere else, you are expected to go down and to start treatment promptly because it affects the outcome of their joint, basically.
Okay.
So you assess within 15 minutes, treat within 30 minutes, and then other things to think about are physiotherapy. There's also this acronym PRICE, which is protection, rest, but you want to keep the rest to a minimum, but you still need to rest it. ICE, which is a maximum of 20 minutes per application, compression, and elevation. So that's PRICE. As you said, tranexamic acid always, and analgesia. Okay, so those are the other elements of management of a joint bleed that you need to consider. We'll just go through some of the other levels to fill out your table. So these are always peak levels that you're aiming for. So you've said a joint bleed 50 to 60, or if it's severe, 60 to 80. Then you've got an iliopsoas, so a deep muscle bleed. What do you reckon you'd aim for with that?
I'm guessing more.
Yeah.
So it's 80 to 80 plus.
80,
Yeah.
80 to 100, yeah, exactly. Intracranial hemorrhage, 80 to 100.
Yeah, I was gonna say go big.
Yeah. So 80 to 100. You don't really want to go over 100 because you are predisposing your patient then to thrombosis,
Yeah.
particularly when they're in hospital. So they've already got VTE risk. Throat and neck bleeding, again, 80 to 100. GI tract bleeding, 80 to 100. If they've got a deep laceration, then 50. Sometimes for hematuria, depending on what's causing it, 50. Obviously, don't give tranexamic acid in hematuria because you'll just cause clot retention.
Yeah.
And generally speaking, for an on-demand bleeding situation, you keep their level at that peak for 1 to 3 days. Okay, and then you have a sort of lower target, usually around, if you've gone to 100, coming down to 50 for then the following 4 to 7 days post-bleed. Okay, and that's generally where you aim for. But again, as I said, loads of guidelines have good tables. Just take one and put it in your notes and have it as a reference. Okay, shall we do a case then, David?
I've been furiously scribbling as you've been saying numbers.
Oh, very good. So you're ready. Okay.
Well.
So
Come
these
at
are
me.
all completely made up.
Okay.
So I'm sorry if they're not actually true to life.
Yeah.
24-year-old male, swollen knee, comes to A&E, has haemophilia A. That's all you know. That's all you've been phoned. What are you going to initially look up on the computer before you run down and see them in the next 15 minutes?
So he's come in with a swollen knee.
Swollen
Well,
knee.
I guess from a completely medical point of view, I want to make sure that it's. I don't know. Suddenly I'm going a bit sideways. I don't want it to be a septic joint. Is basically all I was thinking. But I
Okay,
don't know what to
fine.
look
But
up on the
common things are
computer.
common. We're going to assume that this is somebody with
Yeah.
haemophilia A is probably going to be a joint bleed. But yeah, obviously always think about a septic joint. But the patient's going to come in and say, yeah, it's classic. It's the same as it always is. It's into,
Okay. So I'm going to want to know whether what his normal factor 8 level is, whether he's
yeah,
severe, moderate, or mild.
yeah, exactly. So yes, and so you're going to log on to your computer system and you're going to look up the last level that the patient had
Yeah.
and get an idea of what their baseline levels are, and that's going to tell you what the severity is. What other information might you need to decide on on-demand therapy based on what we said right at the beginning of this on-demand therapy chat?
Whether he had prophylaxis as a child, whether he has it ongoing.
Okay, yes. Whether they're on prophylaxis, useful, yes. What about inhibitor status?
I mean, that would be helpful as well, I imagine.
Exactly. So inhibitor status is going to influence what we can give. And then what they might have tried at home, what their emergency plan is, because these patients are going to have a plan for at home. And I'm not sure if I really told you about that actually, but mild patients and, well, all patients will have an emergency plan for how to manage themselves at home first before they then come in. And that's reviewed every year. So knowing previously what they might have had when they've had a joint bleed in the past. So see if you can find a clinic letter, previous adverse events to that. Did they overshoot and end up getting a clot, or did they not respond very well to X, Y, or Z? And also infection status would be useful for you to know in terms of hepatitis and HIV as well. Okay, so unfortunately for you, which is a common situation, there's nothing on the computer. We've never met this patient before. So in that situation, what do you think is the safest thing to do? What would you assume the patient's level is if we've got no information about them?
I guess you assume it's severe.
Exactly. So just say that their level is 0 for all intents and purposes. Good. Okay, so you go down to A&E, and actually he carries a haemophilia A bleeding card, and on it says that his level is 0.3 IU per DL. So, i.e., he's what category of haemophilia?
0.3, so
Yeah.
he's severe.
Yeah, good. Okay. And when you assess him and you assess his, did we say knee?
Yeah.
It looks like a moderate bleed. So there's some range of movement, but it's certainly swollen, painful.
Okay.
And he's on holiday down in Cornwall because great holiday destination. And so he didn't take his rescue meds with him. He didn't take anything at home, which is why he's come straight into A&E. So what are you going to do? What are you going to do?
So I'm gonna give him some recombinant factor 8.
Okay. Yeah.
I'm going to be aiming for a peak of 50 to 60.
Yeah.
I'm going to give him 1 international unit per kilogram, but that was going to, so I half the target. So I'm aiming for 25. So I'm going to give him 25 international units per kilogram.
Okay. Yeah. Lovely.
Yeah?
Yeah, that's correct. I work it
We
out.
should call it here. Let's the episode's over, guys. I've got a single answer right. I need to cash this in.
No, that's really good. So yeah, as you say, 1 international unit per kilogram dose increases your blood level by 2 international units per DL. If you remember that fact, you'll be able to work out the rest. I actually work it out by saying, okay, what's the level? 0. What do I want to get to? 50. And I say, okay, so the increment is 50 minus 0, which is 50. And then that's the increment. And then what I do is I divide the increment by half at that point. Yeah. And then that gives me my dose in international units per kilogram. So that gives you, so 50 divided by 2, 25. And then let's say he's 60 kilograms. So it roughly comes at about 1,491 international units when I calculated it. So
Okay.
then you just have to make sure that you then go on the BNF and look at the vial sizes that, let's say,
Yeah.
we're going to give Advate. So that comes in vial sizes, because I've prepared this one earlier: 250, 500, 1,000, and 2,000 unit vials. So you're going to give the dose 1,500 international units.
Yeah.
Brilliant. So that's what you're going to do. And you're going to treat like that for a couple of days after the pain resolves. You're going to get
Yeah.
physio, you're going to do your PRICE acronym, and you're going to give tranexamic acid. Brilliant.
Deal.
So there you go. You're ready. Let's do another question then, since you're on a bit of a roll.
Yeah, a roll of one.
Okay, sorry, that came across as really patronising.
Yeah, but
I
I've been
didn't mean it
murdered all
to.
night on
I'm
things
sorry.
I don't know.
Okay, so 38-year-old male,
Yeah.
coming in needing an appendix removed. So an urgent surgery. He's septic. What information do you want to get?
Inhibitor status.
Yep,
What his previous level was.
yep,
And what he has previously been given and what works for him.
yep, good. And infection issues
Yeah.
as well. Good. Okay, so his level is 30. It looks like that's what he runs at.
Okay.
So what are you going to do?
So if I'm doing an operation, I'm aiming for 80.
Okay.
Yeah.
Yeah, 80 to 100.
Okay. Yeah.
Sorry.
So I'm gonna take my 80. I'm gonna take 30 away. So I've got 50,
Mm-hmm.
which is my target.
Your increment, yeah.
My increment. Apologies. And I know that it's going to be 2 international units per deciliter. So he again is 25 international units per kilogram.
Mm-hmm. And is that what you're going to do then? You're going to give Advate?
That's yes.
Oh, it's a trick question. She got him.
Oh.
Is this level of 30? Is it? I mean, you calculated it beautifully. So
he's mild as a general, isn't he?
he's mild. So,
But I don't know the answer to this question. Whether you top them up as you would with platelets or something.
no, not platelets.
No. I'm saying as if he had platelets, you top them up.
Fine. I was like, come on, David.
No.
I was
I
like, have I told you nothing?
Some vestige of hematology knowledge.
So no, DDAVP, that's where this is going to come in. Okay, because this is a mild patient. So ideally, particularly for mild Haemophilia A patients, you don't want to give them recombinant factor VIII when you don't have to.
Okay.
The reason for that is because they can develop an inhibitor to the recombinant factor VIII that you give. Yeah. And so they can start off with a mild bleeding phenotype, and then they develop an inhibitor, and suddenly you've blessed them with a severe haemophilia phenotype, and they're not going to thank you for that.
No. Okay.
So, and they'll have an inhibitor, so it'll be more difficult to treat. So particularly, I chose this case of them being infected and septic, so a good old inflammatory storm going on. These are the times when, if possible, you want to avoid giving recombinant factor VIII because the immune system is ramped up. It's ready to make an inhibitor, okay? So DDAVP would be a great option here. So tell me, do you know anything about DDAVP in the treatment of haemophilia A?
So only what we very briefly touched on in the last episode, that it's a vasopressin, so it releases a pool that's stored in your lungs. That's as much as I've got.
Yeah, okay, great. Well, you're right. DDAVP, also known as vasopressin, is something that can be given intravenously, subcutaneously, or we used to give it as a nasal spray, but I haven't seen that around for a very long time, which is a shame because people used to be able to use that at home for, breakthrough bleeds in mild haemophilia A, but I don't think they manufacture it anymore for whatever reason. But basically, it can be used in mild and moderate haemophilia A patients. And how it works is exactly as you say, it causes the release of a releasable pool of factor VIII from the endothelium, particularly in the lungs. And so it can increase your factor VIII by a level of 3 to 5-fold. So it is therefore dependent, the appropriateness of its use is dependent on what that patient's baseline factor VIII level is. Obviously, if you're severe haemophilia and you've got a level of less than 1, Like you can't make nothing from nothing, can you? So it's
Yeah.
not going to help you. But
If you triple 0.3, you're still
you're
in
still
trouble,
in
aren't
a
you?
bad situation. Yeah. As if you've got a level of 30 and you triple
Yeah.
that, actually you've got yourself to 90 potentially.
Yeah.
Um, Side effects or cons to this use of the
So
drug?
I guess as a vasopressor,
Mhm.
vasoconstriction,
Yeah.
fluid retention,
Yeah.
because effectively ADH. So yeah,
Yes, exactly. So flushing, hypotension, fluid retention, hyponatremia, and arterial occlusion with the vasoconstriction. So to use it safely, you must fluid restrict a patient to 1 litre in the next 24 hours after using DDAVP. And there are certain situations in which I would completely avoid it. One is atherosclerosis. So if the patient's known to have coronary artery disease, do not use
Mm,
DDAVP because you might give them an MI. For that same reason, we generally avoid it in patients that are 65 years and over. There's no hard and fast rule. I've looked at loads of guidelines trying to find like a dead on cutoff as to where you can and can't use it. It's around 65. And that is also tailored to whether they've had previous MIs, if they look frail or fit. I wouldn't use it in less than 2-year-olds either because of affecting, how they can handle their sodium. And also in patients that have risk factors for fluid retention. So if they've got bad kidneys, if they've got heart failure, if they're on loop diuretics, if they're on systemic steroids, if they've got uncontrolled hypertension, I would not be giving it to those patients either. And also, if they've got possible raised intracranial pressure, also not appropriate. Okay. So essentially, it's a great drug for people with mild or moderate haemophilia A that need a boost in their factor VIII levels. You want to avoid giving them recombinant factor, and they're young, essentially. They're young and otherwise well, but not too
so
young.
you picked an appendix. Good.
Exactly. Yeah.
Nice case.
Yeah. And the other thing to be aware of is that you can repeat doses, but it exhibits tachyphylaxis which is basically that it becomes less effective with each repeat dose of DDAVP. So it's kind of a give it once, get them over an operation, and then move on.
Yeah.
And I guess that's because the pool is not
Yeah.
unlimited. Once it's released, it's released. And ideally, if you're going to use it electively before an operation, you should do a DDAVP challenge in an outpatient setting first, which is where you basically give the DDAVP IV, then you measure a level at 15 minutes to capture the peak, then at 4 hours to capture the early fall, and then maybe even 12 hours if you're being really thorough to catch the late fall, so that you get an idea of how that patient is particularly going to respond to it, which might be reassuring. I would find it reassuring. And in terms of the how quick it works, you can give it IV, which will take then 15 minutes to peak, as we just said, or you can give it subcut. I don't know why you would, particularly, I guess, if you didn't have IV access for whatever reason, and that will peak
On their way to theatre. Yeah.
Yeah, yeah, no.
You'd hope.
Hope not. But yeah, and that peaks at 60 to 90, so after about an hour, basically. The dose is 0.3 micrograms. I repeat, I'm going to lean into the microphone. Micrograms per kilogram. I say this because I have seen people be accidentally overdosed as milligrams rather than micrograms, which obviously with all of those fluid retention, sodium side effects, etc., it doesn't look so good when you're looking up the consequences that potentially could cause on tox space, believe me. So it's micrograms. But yeah, so that's what I would have given that guy. You fell into my trap perfectly.
You
Thinking I
tricked me.
planned.
You tricked
Yeah,
me.
I did. I
Well,
did.
your consultant training is progressing well. Yeah.
Okay, so then I guess we need to talk about management around surgery because that's also going to be a bulk of your on-call. And when you get to do your H&T jobs, I'm sure part of your weekly schedule will be going to a hemostasis and thrombosis MDT, where these operations that are electively scheduled are discussed. So it's really important that an MDT plan is made and documented and circulated to all the relevant parties. So that's the anaesthetist, the surgeons, and then other things that you think might be important to think about in terms of.
I guess aftercare.
Yeah.
think about measuring levels afterwards.
Yes.
And
Making sure it's not on a Friday, the operation.
make sure it's not on a Friday. Make sure
Yeah,
it's first on the list. Yeah,
exactly.
these are all the disasters, aren't they? That
Exactly.
Okay.
Make sure the lab are aware and are expecting levels on those days to be done, particularly if you're in a district general hospital, and make sure that there's a bed booked overnight as well, because it might be a normal day procedure normally, but they're probably going to need to stay in to have levels and factor in the morning. In general, just to talk you through kind of how it usually looks, the patient comes in and you calculate the dose of Refacto or Advate, whatever you're going to give them. And they will have normally been on tranexamic acid like a couple of days beforehand or the day before and then 5 days after. And basically you'll give an IV dose of, let's say, Advate, and then you're going to check the level 15 minutes before the knife is to skin, to check that the levels look okay before you start the operation. And then you want to do your next check at 4 hours. So you do 15 minutes, then you do 4 hours. And at 4 hours, that's usually in the recovery bit. So it's quite easy to get one of the recovery nurses to take it if you don't have a specialist hemostasis nurse. It depends what your setup is at your hospital. And that 4 hour dose will then inform you as to what level, what you're going to give them in the evening, okay? Because it will give you an idea of how quickly that's coming down. And usually I find that in the evening they need half the dose you gave them in the morning, okay? And
useful.
yeah, it's just useful tip, generally speaking. And then you'll do your next level in the morning. And in the morning, you will wait for that level to come back before you give your next dose of factor. Okay?
Lovely.
Which, generally speaking, will be like roughly the same as what you gave the day before, because it's a 12-hour half-life.
12-hour,
yeah. So it will be kind of 50% and then down to like 25% by the next morning. Does that make sense?
Yeah.
Okay,
Yeah.
brilliant. And then I guess sometimes patients, if they're in for a prolonged period and they're having their factor levels like maintained for a prolonged period, do actually end up needing VTE prophylaxis, ironically. So it's about thinking about that and talking about that potentially in the MDT as well and making that part of the plan. I think the final thing to talk about before I fire quick cases at you, which I know you've been looking forward to this whole time.
Which everyone at home is like, here we go.
Is the Comprehensive Care Centre annual review. So there's just a couple of things that they will go into more detail reviewing each year when they go to their kind of hub of their hub and spoke model. So when you see them in the annual review, you need to review their treatment episodes. So what products they've had, the dose, the venous access, whether they've needed any prophylaxis before, and why they're now needing treatment on demand. You can review an app called the HemeTrack app, which is basically a record of like their compliance essentially to treatment. And it allows you to look at breakthrough bleeds, and it allows you to like assess basically what their treatment has been over the last year. You should also, if they're on prophylaxis, be assessing their response to prophylaxis, so quality of life scores, MSK health scores, looking at their joint scores and whether there's any deterioration in any of these scores will make you kind of review again whether they're on the right dose of prophylaxis. And then other things is making sure that they are familiar with and understand how to action their kind of emergency plan for at home in terms of the initial dose, the initial frequency, and when to contact the hospital for further advice. They need to have their hemorrhagic states card, which is really useful, like in that case we were talking about, when you have no history, particularly when they're from out of area. And then any orthopedic issues, so review all of their joints, perform a haemophilia joint health score, which is usually done by a physiotherapy attached to the clinic. A physiotherapy review, offer referral to surgeons or rheumatologists as may be required. And then in terms of school or job, it's about time missed, whether they have a living allowance, whether they've got travel arrangements, and then also ensuring that they're vaccinated against hepatitis A and B, which are obviously given subcut, not IM. And also checking their hepatitis B titer is above 100 to make sure that they are still immune. And then in terms of bloods, it's full blood count UNEs, LFTs. You always do an annual inhibitor screen, an anti-hepatitis B surface antigen titer, as we said, a trough factor level to make sure that it's between 1 and 3, and a viral screen. And then radiology if there are any joints that you're worried about. And then just also remembering that there are increased risk of osteoporosis, probably because they don't do as much in the way of weight-bearing sports, potentially. Hypertension and intracranial hemorrhage, so thinking of other risk factors, particularly as they get older, for those things. And that's like your annual review. It's like quite a sort of classic essay or Viva question, I guess, so it's worth knowing even if you don't work in a comprehensive care centre. So yeah.
Nice.
Okay.
One-stop shop.
One last thing, did I tell you or did I ask you what a target joint was? I feel like I might have used that terminology without telling you what it is.
Is that a one that people specifically have trouble with?
Yeah, exactly. So it's where you've had 3 or more bleeds into a single joint within a 6-month period. Yeah, and so it can be a problem, obviously. And so sometimes if you do develop a target joint, sometimes you end up having to have either like a radioactive synovectomy, where you use a radioactive isotope to cause atrophy and fibrosis to basically improve function of the joint, or sometimes intra-articular steroids or like proper surgery. So yeah, that's a target joint. Sorry if I use that terminology without explaining it. Okay, are you ready for some cases, David?
Let's say yes.
Okay, great. Yes, he's ready. He's excited. So just a couple of very quick fire cases. I don't need the math calculations. I've just made up these cases to illustrate some points and to make sure that we're happy that we now know how to do the basic management of haemophilia patients from today's podcast. Okay, so an 80-year-old male with haemophilia A has factor VIII levels of 24 and has an elective cancer operation of bowel surgery to remove colorectal cancer. What are you going to give?
I'm not going to give him pressors.
Very good. So you're not going to give DDAVP.
He's old. And
he's too old.
And he's probably got comorbidity. So excellent. I think we would give recombinant factor VIII.
Yeah.
We would do some maths. I think you said 24, and we're aiming for 100.
Yeah.
So difference is 76.
Yeah.
And then I'm going to half that. Yeah. So 30 something, 8.
Yeah.
International units per kilogram.
Perfect. Very good. 15-year-old male, swollen joint, haemophilia A, factor VIII level of 0.2. Anything you want to consider in this one?
You've given me a child.
Yes, exactly. Yeah, well, no, it's true. So very good. Just make sure you are speaking to a peds hematologist rather than just.
Is there different calculations for kids? Or
no, it's still the same. It's still roughly, the whole 1 to 2 thing, but they can clear it more quickly. And just in general, if they're under the age of 16.
Yeah, sphere of competence type thing.
Yeah, just exactly. Involve a peds hematologist. Good. Okay, 50-year-old male, haemophilia A, comes in with an ileopsoas bleed, and his factor VIII levels are 30.
So deep bleed, I'm aiming high.
Yeah.
He's 50.
Yeah.
We haven't mentioned any past medical history, so I'd ask about those things.
Very good.
But I'm hopeful he doesn't have anything cardiac related.
Yeah.
And therefore we can give him the DDAVP.
Perfect. Okay, a 30-year-old male came off his bike.
Sorry, I'm surprised at myself.
What, that you were right?
Yeah. I was waiting for you just to be like, no, idiot.
No, you're right. Yeah, no, very good. 30-year-old male came off his bike and hit his head. He's got a factor VIII level of 10, and he's, let's say, drowsy and resus / he's got a headache or whatever, they're worried. They haven't done a CT scan yet. Are you going to wait for the scan to look for a bleed, or what are you going to do?
Oh, good question.
And he's 11 of 10, so he's mild.
But if he's got a bleed in his brain, we're going to aim really high, aren't we?
Yeah.
But he wouldn't be a candidate for pressors if we're worried about intracranial
Very good.
hemorrhage, stroke pressure.
Yeah,
So,
not giving DDAVP.
So he'd be for a recombinant.
Yeah.
As long as he doesn't have an inhibitor or what have you.
Yeah, exactly. So 100 minus 10 is 90 divided by 2, so roughly 45 international units per day. Yeah, brilliant. Okay, now I've got a 2-year-old male, slightly different, but 2-year-old male, factor VIII level of 0.1 international units per DL. We're just pretending now that we are working within the peds sphere, by the way.
Oh, yeah.
We just transitioned smoothly.
Yeah.
Started on 3-weekly primary prophylaxis with a portacath in place, compliance issues at home, busy household, 3 other children as well. He's 2, so he's just starting that wonderful age of tantrums. And he and the family are really struggling. And he presents with a joint bleed, and this is the second he's had this year. What information do you need to know, and what are you thinking about just roughly management of this patient?
So I guess the problem's compliance, isn't it? And he's coming in to have, or he's having at home the doses often, but not often enough. So I want to know what his trough level was.
Okay.
And if it wasn't satisfactory, I'd want to change his medication so he had something a bit longer acting.
Okay.
Potentially, if he's a candidate for the EFA or maybe the Emicisimab.
Yeah, or even just the extended half-life.
Just the extended half. Okay.
Yeah, exactly.
So it's a pragmatic thing. It sounds like.
Yeah, this is a case of treatment burden. So if we can switch to something that's less arduous for the family and for the child, that would be better. Good. Okay, and then final case: 24-year-old male presents to A&E with a swollen knee, and he's on Emicisimab once every 2 weeks, and he has an inhibitor. What are you going to do?
Not give fever.
Very good. Yes, you're right, actually. And the answer to the rest of it is you'll have to tune in for next time. Way. So,
oh my goodness.
Next time. So if you want to find out how to
manage a hematology Yoda.
If you want to find out how to manage that man, then tune in next time. So, main learning points, David.
Yes.
1. There is prophylaxis and on-demand treatment, and I think it's useful to have those 2 different aspects of management of haemophilia A separate in your head, and be aware of what agents are available to do both. So your prophylaxis, we talked about recombinant factor VIII, as well as extended half-life, very extended half-life, and Emicisimab. And then we also talked about on-demand therapy with recombinant factor VIII and DDAVP as your 2 main options, excluding inhibitor patients. Number 2, 1 international unit per kilogram of recombinant factor VIII infused raises your blood level by how much, David?
2 international units per deciliter.
Perfect. And 3, wherever possible, use DDAVP in patients who are eligible for it, that have enough factor VIII at baseline. But be aware of the risks and the contraindications to using DDAVP. Do not go giving grannies DDAVP. You will regret it. And that's so that we can, but we're trying to maximize DDAVP use to minimize the occurrence of an inhibitor forming, particularly in somebody who's got mild haemophilia A. Lovely. We've learned so much today.
Yeah, we really have.
What do you reckon? Did you enjoy that?
I mean,
was it as bad as you thought it was?
I feel like you got some good punches in, if I'm honest.
Come on, David. You just got all of those cases right.
I butchered my way through, sure.
So you did a good job. So yeah, I hope everyone at home has enjoyed that too. But haemophilia A, great condition, really interesting. Lots of really cool drugs, quite cutting edge, I would say.
For all those budding hemostasis nerds out there.
Yeah. So Okay, so next time we'll talk about management of haemophilia A patients with inhibitors. And we hope you can join us then.
Yeah. See you next time.
See you later. Bye. Thanks again for listening to Basics to Brilliance Haematology podcast. If you enjoy our series, please don't forget to like, leave a review, and hit subscribe to never miss an episode. See you next time.